Well, g'day and welcome to episode 2 of ACT TV's second season after a highly successful season 1 last week of 5 episodes at 7 o'clock, getting rave reviews all over the place, even put on TV1, so you can say it's ACT TV as seen on TV. We've decided to go through for a second season of 5 episodes this week, and tonight we're going to be joined by a very special guest, Emeritus Professor Des Gorman, who, in my opinion, is the most expert and fearless commentator who will actually call a spade and give people perspectives based on data and evidence about what is really happening in this epidemic day to day. So we're thrilled that he's joining us. I should probably give a little bit of a wrap about what's happened today. Of course, if you live south of the Bombay Hills or south of a particular street in the northern Waikato, then you're going to be a little bit better off. You can at least get takeaways, but there's still going to be enormous carnage and suffering for a huge number of people in business. Schools still not open. And the South Island, despite not having a case for over 300 days, the government is somehow unable to say clearly their contact tracing has eliminated the possibility of further cases in the South Island. We also had today the return of Parliament and 49 new cases. Those 49 new cases are a good number at the headline. It's better than 53 yesterday, better than the number before that and the day before that. We finally appear to see that curve starting to bend down. But there's another critical number within that 49 that we need to understand, because it tells us whether level 4 is actually working, or are there still chains of transmission going on even under those conditions? And that's the 17 people who were diagnosed or tested with COVID-19 announced today who were not in households that already have it. Because the nature of Delta is it spreads so easily through the air. If one person in a household gets it, then pretty much everyone gets it. The purpose of level 4 is to keep people in separate bubbles so that that doesn't happen. However, those 17 people are in new bubbles that didn't previously have COVID, and it might make us think that perhaps COVID is still spreading under alert level 4 conditions. And if that's true, if the policy response we have right now is not working, or at least is working very slowly, that tells us a bit about what we might expect to happen in the weeks ahead. So I asked Chris Hipkins in Parliament, which was back today, what exactly he can tell us about those 17 and how many cases there's been of bubble-to-bubble transmission of COVID under alert level 4. It was really great to have Parliament back today. We are a democracy where everybody gets asked to vote and elect their representative to go to the House and actually ask the questions that people want answered. We're not a dictatorship where one side of politics gets to have the podium of truth each day in a live format with journalists there, and the other people that someone else voted for have to stay home. Today, we actually got some political equality, and having that forum is hugely important. I used that forum to ask about those 17 cases, and you can judge for yourself what transpired by checking out this clip.
Does the Minister know how many new infections have been transmitted between bubbles under this order in the last 2 weeks of level 4?
Mr Speaker, no, I don't have an accurate number, an accurate estimate of that at this present time.
Well, how many cases of transmission between bubbles under alert level 4 in the last few weeks is he aware of that have been confirmed?
Mr Speaker, I don't have that number. What I can tell the member in terms of the numbers that I do have is that we're seeing with each new case that's identified each day that the number of new locations of interest that those cases are throwing up is getting down to a very, very small number.
How can he be satisfied that the current alert level 4 orders are working if he doesn't know how many inter-bubble transmission cases there have been, and the whole point of a level 4 is for people to remain within their bubbles to the extent possible?
Well, Mr Speaker, perhaps if we were doing this via Zoom rather than with all the distractions of the parliamentary debating chamber, the member might have listened to my previous answer where I addressed that.
Why does it make sense for people to drive past their beloved butcher who's going broke in order to stand in a queue with many other people at a supermarket.
Mr. Speaker, other New Zealanders, those who are not in this debating chamber, are being asked to limit their movements to that which is absolutely essential.
And that's the beauty of Parliament and why we needed a proper parliamentary question time brought back. I've long wondered why there was so much contempt towards butchers, why it took 18 months to not fix the rules and do the sensible thing, which is allow a butcher to have a one in, one out system so people can get their meat there and keep that business alive instead of queuing up at a supermarket where the meat shelves have often been empty. Of course, they might say, well, there's more people distributing and doing deliveries to butcheries, but one moment, butcheries that can do home delivery are allowed to, just not those that weren't set up for it when the alert level came. Anyway, I guess in that answer and that attitude, you can see how this government really thinks about some of the people it says that it's protecting. So much for them. Tonight, as with Act TV each night, we've got a guest, and tonight we've got a very special guest who is Emeritus Professor Des Gorman. Professor Gorman is a former Dean of the Medical School at the University of Auckland. He consults widely around the world on healthcare reform and healthcare policy, and he's been somebody who's become a go-to for the media who want somebody who will call it straight and give it the facts. It seems to be a bit of a trend around the world that when there's a public controversy, it's those professors who have had a long career and have a bit more freedom and aren't so worried about the next promotion who are prepared to openly speak out and be critical, swim against the tide and ask questions and give answers that other people might not want to be asked or given. With that, I want to welcome you here, Professor Gorman. Nice to see you again, and thank you for making your time available.
You're welcome.
Yeah, just a lot of people will be really interested to hear your perspective about how we're going in terms of the government's response, and then having looked at how we got where we are, where we go next and what the government can do to ensure that the response in future doesn't end up relying on lockdowns, because you've basically got tracing and then testing and then vaccination. And if those tools don't work to isolate and reduce the impacts of the virus, then you're back to the bluntest and most costly tool of all, being lockdown. So what's your take on the adequacy of the response to date, and perhaps talk a bit more about what could happen next?
Thanks, David. Well, I think the simple reality is we're in a lockdown because all the other public health measures have either failed or have been proven to be inadequate. Our border has been porous from the get-go. We've had more border breaches per capita or per whatever than the Australians did, for example. So the border has leaked. If you think about the Crown Plaza Hotel, where people go in and out of the Crown Plaza, people coming from planes, is next to a public thoroughfare. Where people exercise is next to a public thoroughfare. There's a vaccination centre, for goodness sake, in the middle of the Crown Plaza Hotel. The ventilation's still so bad that the infected Apex case, when he opened his door and a family across the corridor opened their door, they all became infected. So the border management remains very leaky. There has been an absolute reluctance, sadly, to consider and actually get on with building a dedicated quarantine facility. We continue to quarantine people in hotels with poor ventilation systems for purpose in the middle of our largest cities. It's nuts. So our border, the first reason why we're in lockdown is because our border leaks. The second reason why we're in lockdown is all our other public health measures really aren't good enough. If you think about it, testing, contact tracing and vaccination, those three public health measures have all materially failed us. We've had an incredibly slow vaccination rollout for reasons I don't think are acceptable. We were late to order the vaccine. We were late to confirm the order. We didn't order enough. Then we find out that we were supposed to have the big order coming in the third quarter. Then we told no, it's going to be after the third quarter. Then we find out yesterday the government actually asked Pfizer to slow it down, which I find quite extraordinary. How should the vaccination have gone? Look, it's dead simple. You basically say we need to vaccinate the following groups. Number one, the vulnerable people in our community. And that's easily identified. If you ring the GPs, any GP, any primary care network and say, who are your vulnerable patients? Who are your vulnerable people? They'll give you a list in 5 minutes. They'll just go to the flu vaccine recall list, push it and print it off. You can then have said to the GPs, I want you to identify your vulnerable people in whānau. I want you to contact them and I want you to convince them to have a vaccine. I want you to vaccinate them. Here's a bucket of money to do it. And for everyone you don't get, we'll take money away from you. So you use loss aversion as a way of driving that good behaviour, but you use your primary care network to vaccinate the vulnerable. The second group you need to vaccinate are the essential workers, hospital workers, border workers, and so on. And in fact, we now find, in fact, that most DHBs don't even know who of their staff have been vaccinated and who haven't. And in fact, we find out, as you guys have pointed out, as David's pointed out to you, more prisoners have been vaccinated than prison guards, for goodness sake, which is a very sad irony. And the third group you need to vaccinate are not the elderly people of parts of the South Island. I've never seen a single case. It's young people. Young people are the vectors of this infection, and it's young people in South Auckland. And so there's been this reluctance to actually accept the vulnerable, the border workers and essential workers, and the vectors who are young people. And the way to manage it, in fact, was to engage the best logisticians from Freightways and the best supply chain experts from Foodstuffs and Woolworths, and to put together and stand up an agency like we do for biosecurity to actually get the vaccination done. In fact, we haven't done that. We've relied on DHBs who don't know the vulnerable communities, don't know the vulnerable people, don't even have they can't even tell you the number of people in their groups 2 and 3, for goodness sake. The next thing you look at is contact tracing and testing. And you saw, every one of us has seen what happened in the first day of this breakout. They were simply swamped. They've had 8 months to prepare. We've known about Delta since it emerged in India late last year. We've had lots and lots of warning. And in fact, it reflects a culture that we've seen throughout pandemic management of a reluctance to learn. Sam Morgan prepares a card which enables contactless tracing, rejected. We're still using a phone app, which for goodness sake is steam driven. We all turn a Bluetooth on. They haven't used Bluetooth. They don't know how to upload the data. We're not using a land force. We're just relying on people ringing and ringing and ringing iteratively. Contact tracing has not lifted over the last 18 months. We're still running way below 50%. The critical figure is this, by the way. How many people of interest can you identify, contact, test, and dispose of? And the answer is Isha Varel in her very good report, notwithstanding her lack of declaration of a conflict. In a very good report, she said we need to identify 80% of people within 4 days. We've never got above 50%, and it's plateaued there. In our testing system, we've known that we have saliva testing, rapid antigen testing, and PCR availability for last 15 months. And by the way, PCR testing on saliva is almost certainly as good as nasopharyngeal swabs. And one of the things I recommended to one of the media tonight is that the essential workers should be doing a spit test every day because it's non-invasive and it's easily accessible. So the answer to your question, David, is that we're in a lockdown. It's going to last longer than it needs to because we're not vaccinated. We can't contact trace the level we need to. Our testing system is very, very limited. And so those public health failures, and it's not a failure of the public health people to identify the measures. People like David Skegg, people like Michael Baker have been identifying what we need to do from the get-go. I have no argument with those guys. I admire them. It's been an inability to execute. It's been an inability to deliver. It's a systems failure. So we're in a lockdown now that's avoidable. We're in a lockdown now that's longer than it needs to be. But, you know, the irony is, David, that we've got to put aside the forensic analysis to some extent, and we've got to say to people there's a prize for good behaviour. We've got to incentivise good behaviour, and that's the final thing I'll say before I move on to your next question, and that is the messaging that we're getting is awful. It's disincentivising. They're using modelers who are doom and gloom. They see dragons in every single cupboard they look in. They just present the information in a way which disincentivises. For example, there's got to be a reward for vaccination. France is doing it. Canada's doing it. If you want to go to the movies, you need to be vaccinated. If you want to go to a restaurant, you need to be vaccinated. There's got to be some incentivisation. You saw yesterday the data presented on that unfortunate person who died of myocarditis from the vaccine. And the information was presented in such a way, the only thing it can possibly have done is made the anxious more anxious, the vaccine hesitant more hesitant. That was an awful way of presenting health information. So the answer to your question, David, is we're locked down because it's the only tool I've got that works.
There's a huge amount there. So many questions, but a couple. One is just to go back on that myocarditis, because a lot of people will be spooked by that. People who are on the fence, people who say, look, I'm not an anti-vaxxer, but I have some concerns about how quickly this one was developed, and mRNA sounds a bit different. Now there's been a death. How should the government have promoted that, or at least communicated that situation?
First of all, I think the population of true anti-vaxxers is quite small, and it's not vulnerable to information. It's a belief, and it's a belief which is established to the point that it has, people who are true anti-vaxxers engage in confirmation bias, David, where they only pay attention to information that fits. But there's a much larger group of vaccine hesitant, and vaccine hesitant people, in my experience, have very good reasons to be vaccine hesitant. I had Guillain-Barré. Will the vaccine make my Guillain-Barré come back? I'm on Keytruda because I had melanoma. Will that cause me problems? So I think the vaccine hesitant require clear and articulate information. In the case of myocarditis, this is how I'd have done it. I'd have said myocarditis is a common infection. We admit at least 2 people every week to hospital with myocarditis. And generally people do very well with myocarditis unless they have a lot of comorbidities, which almost certainly this person who died of the vaccine did. The next thing I'd have said is, listen, the vaccine, the Pfizer vaccine, for every 100,000 people who get it, 1 or 2 will get myocarditis, 1 or 2. On the other hand, if you get COVID infection, somewhere between 11 and 12 people per 100,000 will get myocarditis. And they'd say, look, then the issue should say, well, Des, but you're giving me the vaccine, which means I'm taking a risk of 1 or 2 to 100,000, but I don't have the disease. There's no disease here. And then what you needed to say was this: we need to accept a fundamental truth. Every single one of us is going to encounter this virus. Every man, woman, and child will encounter this virus, either by facsimile through a vaccination or the wild form of the virus. Every one of us will come in contact with it. So the way you'd explain is say, this is the risk and this is the benefit. Informed risk consent is you face a 2 in 100,000 risk of the vaccine, but if you get the infection, you're not vaccinated, then it's going to be 12 in 100,000. And so it requires enough information for intelligent people to make an informed decision. Not, look, sorry, it's rare.
That's a great segue. I guess there's another thing you said earlier on about the vaccine rollout and a lot of the response. It seems that the public health system is very fragmented, very sclerotic, and doesn't have a lot of data. You suggested that getting the best logisticians, the freightways and the main freights of the world involved, might be a way around that. But why is it that the public health system can do some things quite well, like when they have to roll out a huge amount of tests, eventually they get out and do that? When they have vaccines and it's one type and they've had 18 months, they can start doing those at relatively high levels. But why are they not more nimble? Why does it take so much time? And is it so challenging for a whole lot of very well-meaning and very able people to be able to respond?
You're right, David. They are well-meaning. Most of the public health people I know genuinely care, and they're generally trying very hard. They don't have the right skill set, David. They have no experience in operational things. They're not operational people. They're policy people. They don't know how to execute a plan. In fact, they're unable to even produce a detailed plan. They don't understand things like risk appetite. They don't understand things like how do you respond tactically to a certain situation. And the irony here, David, is that our biosecurity arrangements that we use to protect our farms and forests and orchards and vineyards are very sophisticated. We have government industry agreements which enable government to call on the expertise that exists in this society to actually achieve certain things. Now, in the case of data management, I'm entirely on board with what Michael Baker's asking for. Make the data publicly available. Allow the collective intelligence of New Zealand access to the data. Do not withhold the data. In fact, my view is planning for COVID should be a public exercise, David. It should be, all the information should be publicly available. And in your clip that you showed before, God bless you, you identified the absolutely key bit of data we need. Thank you for level 4. It seems to be working, but what I need to know is how many cases have occurred because of infection after lockdown? That's the data I need to know.
And this is something where I completely agree. We want to be treated like adults. We know it's difficult. As you alluded, I think you're right, sooner or later, everyone on the planet will get COVID. The question is what sort of strain, hopefully a much weaker one, and how much have we done to adapt to be able to manage it? That might be a good segue just to one of the questions we've had through from our audience. I think it was, let me just find that again. We had I don't have the name, but I have the question. What things could be done to increase ICU capacity? Because one of the fears that people have is that, you know, most people survive, but if it overwhelms, and especially with vaccination, almost nobody should die from COVID, but it overwhelms the hospital system. The hospitals are already absolutely overloaded. Nurses overworked, report they have to do 16 hours work in 8 hours. What things could government do to increase surge capacity in the case that there was an outbreak, given that, you know, we're lucky for now and we've made big sacrifices and lockdowns, but if there was to be one in the future, what options are there for increasing hospital capacity?
In the case of ICU beds, David, we have the second lowest rate in the OECD. Only Mexico is below us. We have something like 3.6 ICU beds per 100,000 population. And to give you some idea, Germany has 10 times that number. They have 30 odd ICU beds per 100,000 population. The problem with just magicking up ICU beds is not buying the ventilator or buying the bed. It's actually the staff training. And in fact, the problem there is specialised ICU nurses and specialised ICU technicians, as well as the physicians. Now, we've known about this shortfall for a very long period of time, but over the last 18 months, there's been no material change. One of the untold secrets of our health system, David, is that we're the most reliant country in the world on overseas trained doctors and nurses. Something about 45% of all the doctors working in New Zealand are imported. Now, one of the issues that we need to discuss is that if we are to have an elimination approach going forward, that can only work if you have a hard border and if you have frequent lockdowns every time the border's breached. And the problem with a hard border is that we are absolutely dependent on importing skilled workers. And the health system is absolutely dependent upon importing skilled workers. One of the few arguments I used to have with David Clark when I used to meet him regularly was, I said, we are overly dependent on migrants. Migrant doctors are good. They bring diversity, different points of view and so on, but not when it's 45% of your workforce. We're at least 200 medical graduates per year short of steady state. His view was...
I was just going to say that's a great segue onto, well, first of all, just for kids at home, do your science homework. New Zealand needs more doctors and nurses, especially biology and especially chemistry. Very helpful.
Yeah, look, the two subjects that matter, David, actually for medicine,
sure,
as a person around middle school, chemistry and English. I think you can teach any more on physics and biology, but chemistry, if you don't have chemistry, you're in trouble. And if you're not good, you're in trouble.
Okay, kids, advice from a good professor. Chemistry and English are the ones that you should focus on first so that you can serve New Zealand as a locally trained doctor. But it does create a fundamental problem that if our strategy relies on a hard border and having more medical professionals, and our medical professionals traditionally come from overseas, and add into that the fact that the Australians are poaching them right now so everyone can play this game, then we actually need to be much more thoughtful about our border. And that leads to a question from George. Does Professor Gorman think an elimination strategy is viable when we eventually start opening borders, especially as other countries no longer seem to be practicing it? Or should we shift to achieving a percentage of people eligible to be vaccinated, get vaccinated, and move to a manage it or harm minimization phase? So there's a few questions in there from George, but I guess one thing in particular is around what an endpoint to vaccination looks like. I asked the Prime Minister in Parliament today, what does it mean for the vaccination program to be completed? Because Professor Skegg's advice says that we don't really have options until the vaccination program's completed. The Prime Minister seemed to say that means when everyone's had a chance to have a vaccine, but she didn't then say when she thought that might be. She said it's our fault. So yeah. I guess what we're asking is, what does it mean to complete vaccination in New Zealand, and is it possible to continue maintaining elimination beyond that point if the rest of the world isn't?
Yeah, a very good question, George. By the way, over that previous question about limited medical capacity, when you put people into the system, you just simply displace people down. People get pushed out of ICU, they get pushed out of HDU, they get pushed out of beds. So what happens is that if there was a COVID outbreak which had of a bigger size tomorrow, it would mean that a lot of New Zealanders who would need health care for their cancer or whatever won't get it. So what we're doing is incurring a significant unmet burden. To answer your question, George, no, it's not sustainable to have an elimination strategy if the rest of the world's going down a different path. We need elimination now while we get our vaccination numbers up, but long-term, Murray Horn and I have been looking at scenarios of how would you maintain a long-term elimination strategy. And the only way, George, is by every single solution we come up with involves a hard border and a lockdown every time the border's breached. Now, the problem with the hard border is if you're a trading nation relying upon tourists, foreign students, if you're relying on skilled workforce being brought in, how does a hard border work? And the thing about lockdowns is eventually you run out of money and you run out of goodwill. In fact, you probably run out of both very, very fast. So we come back to David's addendum question, which was the Prime Minister clearly, David, is saying the vaccination program is successful when everyone has been able to access a vaccine, whether they're vaccinated or not. Herd immunity probably looks at 90-odd% north. We're not going to get close to that, David. If we get over 70%, we'll have done very well. If we get to 80%, I think that's almost miraculous.
So 80% of all New Zealanders or 80% of over 12s?
Well, that's the point. I mean, as you're seeing now, there's 6 kids under the age of 1 who are sick. Children get this disease. Children spread this disease. I mean, you imagine if we took an approach to measles or mumps or anything else, that we're only going to vaccinate adults. That's ridiculous. At some stage, our vaccination rates have to reflect the total vulnerable pool, which are all New Zealanders. So I think there's going to be one threshold is, in an ideal sense, when do we say, well, we've got to a reasonable vaccination level, we now need to start integrating and start opening our borders. I suspect that's somewhere between 75 and 80%, ideally. But before we get there, David, we're going to have the same problem they're having in the UK and the US. We'll get to 60-odd% and people will say, we've had enough of this. And I think the people, the governments around the world are going, we're losing control. We've got to 60%. There's now this overwhelming desire to open up. And I think, so there's 2 thresholds. One is the ideal threshold, but the other threshold is when do you lose control of the public debate? And given that this whole pandemic's been managed by a public relations approach, the whole thing is about being popular, that makes the government even more vulnerable still to when we hit sort of 60-odd%. It's going to be very hard to hold back the force, which is, okay, we've done the mahi, that's enough of that nonsense. We want our lives back.
We're nearly over time, but I just want to ask one last question that Janice has sent through, that I know a lot of people will have seen the harrowing case of the old man who had to stand by the edge of the cemetery and watch his wife being buried. And I just can't countenance how we as a society can allow that sort of thing to happen. A, it's cruel, but B, it's, in my view, nonsensical. I've given my answer, but Janice's question I should read out before giving my version of it. How is the risk of a small bubble at a funeral greater than being in the queue or moving around in a supermarket at level 4?
Janice, your question's rhetorical. I think making people die alone and making women be alone after they give birth is inhumane. It makes no sense. It makes as much sense as closing the butchers and the greengrocers and pushing more people into supermarkets. If 2 years ago, Janice, I'd said to you that we as New Zealanders would abandon people when they're dying because of a respiratory virus, you'd have said, no way, that's not New Zealand, that's what we are. But I want to remind you that when we were sufficiently scared by the idea of hundreds of thousands of deaths, we were so frightened, we were so self-centered, we rushed home and we abandoned the dying and we abandoned women when they were given birth. Shame on us, because as a society, it reflects very poorly on us. And the observation I make, David, here is that this government, like governments all around the world, have used fear as a powerful tool to manipulate behaviour. And tragically, that fear has generated a lot of political capital. And it's a great shame. But what Janice's question is a rhetorical one. It's inhumane and it's nonsensible.
Yeah. Unfortunately, we have so many more questions, but we've run out of time. We've got a very strict format as ACT TV. So, look, Professor Gorman, I want to thank you for appearing tonight, but also for all the commentary that you've done. You know, we must have thousands, I don't know, tens of thousands of academics in New Zealand, and we very seldom hear from them, other than those who seem to have a very clear chorus. There's a few others, but there's far fewer than there should be. So thank you very much for making yourself available and being available to the press for public comment and for us tonight. I think you're doing New Zealand a huge service by offering your mind, and we wish you all the best. Now, please stay on the line. I just got to wrap up.
Thank you.
Well, look, thank you everyone for watching another episode of ACT TV. We hope that you found it informative. Professor Gorman certainly has some incredibly useful perspective that you're just not hearing anywhere else. Tomorrow night, ACT TV returns for Season 2, Episode 3, and we're going to be talking to two of ACT's members of Parliament about small business. They actually happen to be two MPs that still own small businesses, although largely managed by other people now they are in Parliament. Tony Severin from Christchurch, she and her husband have an industrial water blasting company employing quite a number of people. And Chris Bailey, who owns the Honest Lawyer pub in Nelson, they're going to be talking through some of the pressures that small business people have faced when it comes to going through lockdown and going in and out of levels, and what it actually means at a practical level to be able to pay the bills, pay the wages, have your stock ready to reopen, pay your taxes, and comply with the regulations that government requires, and ultimately come out the other end and satisfy your customer, because there's a lot of people in a very tough space in small business, and we think that they need a bigger voice. We'll be doing that tomorrow night, 7 o'clock, right here on ACT TV. Thank you very much.